going to really focus on vaso-occlusion. So as I said, these slides belong to Afro-Caribbean. She's the clinical nurse specialist for hemoglobin adults at which is a NHS trust. Vesna, can you mute?
Oh, sorry.
Okay. So when we're looking at sickle, the different types of pain evidently in sickle, we've talked about some of the pain issues that occur in sickle. But as I said earlier on, a significant proportion of our patients, 90% of our patients, actually manage their pain in the community. So you'll find when it comes to mild pain or even a certain level of moderate pain, they manage that at home. So most of them will have just use at home, ranging from paracetamol to DF118 to a number of codamol, all sorts of things that they will use at home, which they can get from their GP, and they'll manage that. They'll try alternative therapies like distraction. They will try TENS machines. They'll try all sorts of things to help to reduce their pain. They'll drink lots of fluids. They'll try and rest and go to bed and things like that. They'll even try massage. So mild pain is managed, they don't come to hospital with mild pain. Mild pain is managed at home. When we get to moderate pain, a lot of the patients will also manage moderate pain at home, but they will also try low or weak type of opioid. Some patients have that at home, and they will use adjunct therapies. But usually patients with sickle will not come to hospital unless they're in severe pain, which means they've tried everything else at home and it hasn't worked. And it's when it hasn't worked that they then, come into hospital. So obviously it means that by the time they get to hospital, their pain is excruciating and their pain is severe. And they haven't got, the patience to be able to explain things as well. So sometimes it's quite useful if they come in with somebody or somebody accompanied them to hospital. But in this period of COVID, it's quite difficult for them to always have somebody with them. So they'll tell you that quite often they're not in a fit state to be able to explain things themselves. So it's quite important to recognize that by the time they get to the hospital, they are often in severe pain, and therefore they need a strong painkiller. They need opioids and any adjunct therapy according to your local protocol. So severe pain, this is an example of Imperial College Healthcare Trust, their pain management. But, I always say to everyone on this call, those of you from St. George's, as well as those of you from London Northwest, you need to follow your trust's protocol. This is an example from Imperial. So when the patients are in severe pain, they need morphine or diamorphine or oxycodone. These are how they work out their pain management amounts. Ours, we calculate ours a little bit differently in London Northwest. But majority of patients, once they're admitted and they're in severe pain, majority of patients will go on to patient control analgesia. Patient control analgesia is the key, really, in being able to manage sickle cell crisis effectively in sickle cell disease pain. There are other types of pain in sickle cell disease and medications. Other medications include naloxone, adjuvant therapies. So some of them will have paracetamol, ibuprofen, naproxen, and they'll need laxatives, as we all know. Patients will they're on opioids that can get very constipated, so they always need to have laxatives prescribed at the same profit. They're going to be immobile. Anti-itching, because some of the medications also causes itching, and an antiemetic, again, because of the side effects of some of the drugs, the opiates. But the mainstay of management of pain in sickle cell disease is follow your trust local guideline and protocol, or the patient's individual plan for management of pain. Majority of patients, I mean, the NHCC, what we're saying is every patient must have an individualized protocol or patient care plan, but not everyone has it just yet. So the main thing is to follow your trust's own local guidelines and protocols for management of the patient's pain. This gives you an idea of the pain nursing observations for patients receiving opiates via PCA. This is the PCA observation chart that we use in London Northwest. That you start with a baseline observation prior to commencement of PCA, the usual temperature, pulse, respiration, blood pressure, etc., the oxygen saturation level, and you always use a proper tool to measure their pain score and their sedation score, and their nausea and vomiting score. That gives you the baseline on which to work on to the next level. Then from the first hour, you'll do exactly the same observations again. So observations are every 30 minutes, and the patient is responding. And the pain score is reduced at least by 2 from when they were first admitted. If this is reduced, then you can go on to an hour, every hour, total of 6 hours. And then from the 7th hour, if you don't achieve this, then you go back in the pain management system. Then from the 7th hour, they're still on the PCA. Until the PCA stopped, you continue to do observations at least every 2 hours. And following any change to the protocol, any change to treatment, you may need to go back to level 1 or level 2. So observation is the key when looking after these patients. Observation is the key, because a lot of nurses say, you know, where they have, when the patient is comfortable and they're asleep, they feel that they're okay, and that often is where things then start to go wrong. So missing out on observations can be fatal, and therefore whilst the patient is on PCA, you have to maintain the regular observations according to your local guidelines. Don't assume that because the patient's asleep, everything is okay, because that's when things will go wrong. As we all know, the NICE guidelines says analgesia must be given within 30 minutes of arrival in hospital. That's the NICE guidelines 2015. It's just been updated as well to 2021, but it's still the same, that it must be within 30 minutes of arrival. Evidently, if somebody's had something, somebody's had something recently in the ambulance. Sorry, Ralph. If a patient has been given analgesia, in, say for example in the ambulance recently, evidently it depends on what they've been given as to whether you will be able to provide them with this analgesia within 30 minutes. It may be that they don't need it at this point. And you must always use an observation chart and perform the pain assessment and pain scoring and use a proper tool. Encourage the oral fluids. As I said earlier on, dehydration is the major problem for a lot of patients with sickle cell disease. But if they're not able to tolerate oral fluids or they're vomiting, then you will have to commence IV fluids, because you can't afford for them to get dehydrated, which they can do rapidly. Kidney function is often poor in this patient group. They can't concentrate their urine, and therefore they even the more fluid you give them, the more they will pass urine out. So it's important to recognize that fluid balance chart is a must, and fluid input and output measurement is crucial. Keeping the patient warm and comfortable, and for me the key to patients coming into hospital with sickle crisis is reassurance. We have to always remember our adult patients have had sickle cell all their life. Some of them have been in and out of hospital quite a number of times. So by the time, and all of the patients, I always say to nurses, all your patients know people with sickle cell disease who've died. So as a result of that, it means every crisis they come in with, every time they come into hospital, they are frightened because they think that, is this going to be my last crisis? Am I going to die? And then, so therefore, what attitude or what they meet when they come to hospital become very, very important. And that's what we are best at as nurses, reassuring patients. So somewhere along the line, we need to find a way of reassuring that patient that we care and we're going to look after them and they're going to be all right. So reassurance is key. Reassurance actually brings down their pain. It reduces their anxiety. By reducing their anxiety, their experience of the pain will be reduced. So reassurance is key and very, very vital. I always say to the nurses, always remember, you know, what we're taught from our what we call the PTS days, which is our introduction to nursing, which is the caring attitude, and that always plays a major part in caring for these patients. So prompt assessment of their need and what's caused the problem. So prompt assessment, diagnosis, what's causing the problem, what's brought them to hospital. Is it vaso-occlusion or is it something more severe? So they will be admitted immediately if they've got a severe painful crisis, if they've got an increased pallor, because it means, you know, they've got increasing anemia and what's causing it. If they've got an infection, so a temperature something like 38 degrees, we'll always admit. If they've got an acute chest syndrome, once we diagnose that. If they've got abdominal pain or abdominal distension, even with children as well, we'll always admit them. If they've got neurological complications, because I always mention the neurological, and it's quite an emphasis, because you'll find that some patients, you know, they come in, they seem you know, very agitated, they seem abusive, they seem, you know, all sorts of things that, you know, can be very distressing for us as nurses. And then, you know, the nurses then find, oh, the patient's gone to sleep, and they think that means everything's okay. But quite often, it often means that everything's not okay, because they could be having neurological complications as a result of either or something more sinister. So it's quite important that's why it's important to maintain the observations. So, you know, what is going on? Why is this patient who was shouting, you know, some few minutes ago, why is he suddenly quiet? Go and investigate. We always admit for priapism as well, so involuntary erection of the penis. Once a patient comes in through A&E, it's important to let the hematologist know. There was a recent report that came out about 2 or 3 weeks ago by the All-Party Parliamentary Group for Sickle Cell and Thalassaemia. And this report says, you know, that patients are very distressed that when they come in, that the hematologist or the specialist nurse is often not informed. And so one of the major recommendations is that a hematologist should be informed immediately when somebody is admitted who has sickle cell disease. There was a report that I was the nursing representative on this report. A report was done in 2008. We entitled that report A Sickle Cell Crisis, ? The reason why we gave it that title is because we looked at all the deaths that occurred over a 2-year period to investigate what are the causes of the death, what are the things that led to the complications that caused the person's death. And some of the things we found were quite disturbing, in that you even had people who had, for example, there was somebody who had appendicitis, and everyone in the hospital just put it down to it's a sickle cell crisis. And until that patient had a ruptured appendix, everybody was thinking the abdominal pain was sickle cell crisis. You had patients who had brain tumors that was being treated for repeated sickle cell crisis. So, and that's why we put the title of this report as Sickle Cell Crisis ? In other words, we must always recognize that, you know, like everyone else in society, people with sickle cell disease can also have a variety of ailments that are nothing to do with sickle. So always remember that when we're treating sickle patients. So within this report, what I found that the overall nursing was quite good, but the areas that really needed improvement was that nurses were documenting observations. You know, somebody has a temperature of 39 degrees. They just charted it. They didn't call for they didn't seek medical attention for this patient. So they were doing the observations quite all right. They were documenting it, but they didn't take any action. And that is either due to lack of knowledge, which is probably the case, or a misunderstanding of the importance of the observations that we are doing. So reporting and acting on abnormal observations was a major problem. And that's one of the major contributory factors to quite a number of deaths recently amongst patients with sickle cell disease. One, healthcare professionals are understanding the observations and what they mean. And two, not understanding what they mean in relation to somebody with sickle cell disease. Not understanding the potential side effects of medications, especially opioids. And also not understanding the importance of fluid balance and strict recording of input and output. Because if somebody's in renal failure, you wouldn't know if you're not measuring their output. There was a lack of understanding of the importance of hydration, which was seen in some cases. And out of the 41 patients who died in hospital, 21 had good and adequate fluid balance, 7 had poor fluid balance, and in 13 cases, there was no record of whether they were being, whether measured or not. They didn't even recommend that all sickle cell disease patients should have a carefully maintained fluid balance chart for the whole duration of their admission. While they're still in hospital, they must have a fluid balance chart. Then once they're in A&E, we need to determine whether they need to be admitted. Then you would take bloods for FBC, HB electrophoresis, particularly if they're new patients and they're not known to us. The retic count, check their U&Es, liver function, they do their bone profile, CRP, group and screen. Blood cultures, if they've got an infection, is suspected. So if they've got a high temperature, etc. We always encourage the patients to drink fluids as much as possible. But if they're not able to drink, then we have to put them on IV fluids, at least for the first 24 hours until we feel it's no longer necessary. And they must be started prophylactic anticoagulation and given a pulmonary stocking. Other possible interventions, depending on what is the diagnosis. For example, if they've got chest syndrome, they may need a red blood cell exchange, either manual or automated. Ideally automated, because it puts less stress on the patient as well as on the professionals. Or top-up transfusion. Some patients are commenced on hydroxycarbamide, on hydroxyurea, from when they come into hospital in an acute crisis. If we suspect an infection, as we said earlier on, sickle cell disease is associated with ill-defined immune defect due to being hyposplenic. Their spleen gets damaged very, very early on in childhood. So you'll find by the time they're 2-3 years old, their spleen is really not functioning well at all. So they're very prone to infection, which is the reason why we give prophylactic penicillin to children with, sorry, I need a drink. I've been talking too long. All newborn babies identified through the newborn screening program are commenced on prophylactic penicillin from before they're 3 months old. That's the national guideline. So that's one of the national standards. So we recommend that they continue prophylactic penicillin right through into adulthood, or at least until they finish full-time education. But you'll find majority of our patients still continue having prophylactic penicillin. We also prescribe folic acid, which is a mineral that helps them to make it with their blood production. So the main causes of infection, particularly in this patient group, is pneumococcal gram-negative, lower respiratory tract, urinary tract infections, osteomyelitis, or parvovirus. For most of us, if we get parvovirus, we have a fever and so forth, and our hemoglobin level drops very rapidly. But if you and I are starting with an HB of 12, 13, and we drop our hemoglobin, we'll probably drop it to about maybe 10 or thereabouts. But if somebody's starting with an HB level of 6, 7, and they drop their hemoglobin level because of parvovirus, it's going to drop right down to about 3 or 2. And so therefore that can be quite fatal in these patients. If the patient's temperature is above 38 degrees centigrade, we start them on IV antibiotics and always follow the local trust guidelines and policies. Do a septic screen and order a baseline chest x-ray just to rule out sickle lung. While they're on treatment dose of antibiotics, they stop their prophylactic penicillin for the time being, and then they go back onto it once they once they finish their treatment dose of antibiotics. These patients can be very difficult to cannulate, but it'll be ideal if one can gain a suitable venous access early, so that to prevent infection development to a sickle crisis, so that you have access when you need it for the patient group. Acute chest syndrome. Acute chest syndrome is one of the serious fatalities you see in adults. Rapidly increasing red cell sequestration in peripheral pulmonary capillaries, interfering with their gas exchange and therefore causing severe hypoxia. So you need to establish chest syndrome very early as possible, with chest x-ray and blood gases. It could be a pulmonary emboli, and early intervention is crucial, but particularly with chest syndrome and particularly with pulmonary embolism. Pulmonary emboli is one of the major fatalities that you see in adults. Symptoms include new infiltrates on chest x-ray, fever, as I've said earlier on, chest pain or hypoxia, percentage oxygen below 92, PO2 below 8. The patient will often show shallow breathing. They may be semi-conscious, and GCS below 12, 15. Fat embolism from necrotic marrow, chlamydia pneumonia, mycoplasma, Staph aureus or parvovirus. Sorry, I need a drink. My throat's getting very dry. Sorry about that. So acute chest syndrome, as I said, is one of the serious fatalities that can occur in adults with sickle cell disease, and one needs to ensure that one keeps an eye on that. In terms of management, blood gases as soon as possible. They have to be put on antibiotics, which you need to follow the local trust protocol and policy. In central spirometry, they may be put on continuous positive airway pressure. Quite often, they'll need transfusion, ideally exchange transfusion, and usually within the first 24 hours, either by vas cath or by femoral line. They'll need to have their oxygen saturation measured on air and while they're on oxygen therapy. And they need a suitable pain management outline, either following their individualized patient analgesia protocol or following the local trust pain management protocol for this patient group. Chronic pain is often associated with things like bone damage. You'll find that hip and femur is the most common areas that you get necrosis. And quite often it's very difficult for some of the patients to understand that you can't manage chronic pain with acute medication, because over time that medication will no longer work in managing and effectively managing the pain. And this is where your psychologist and your physiotherapist comes into play, because the patients need to really understand that trying to manage the hip necrosis or the femoral necrosis or other chronic pain aspects with opioids long term will not work will not be effective. And it just leads to increasing resistance and increasing become accustomed to the medication. So it's quite important that we need to have them referred to either the chronic pain team or to the specialist psychologist. Most hospitals now have a specialist psychologist as part of their sickle cell thalassemia team, so that they can work with the patient to help them identify the most effective way to manage their chronic pain. Sometimes they have chronic nerve pain damage, and therefore things like pregabalin is quite useful to help them with that pain. But referral to a chronic pain team is crucial. Depending on what's causing the pain, for example, if they've got hip necrosis, there may be referral to orthopedic team for assessment and maybe possible hip replacement. In caring for these patients, the psychological aspect is quite important because the patients often describe a feeling of helplessness against the disease. As I said earlier on, they live with this condition from a very young age. They've experienced many some of the many crises. They've been in and out of hospital for many times, and some of them feel that the disease is actually having a major impact on their ability to manage their day-to-day living. So therefore, a holistic approach to managing pain is both a physical and an emotional experience, remembering that they've lived with the condition for many years. Stress can be a precipitant of sickle cell crisis. So you'll find some of your patients, maybe they're preparing for exams, or they're moving house, or they've been bullied in school, or things like this can contribute to their experience of having frequent crisis. So they need empathy and understanding. It's important to recognize the role that the social and community support plays. A lot of areas have community specialist nurses that will help to support these patients. So if you find, for example, a patient is coming in and out of the hospital quite a lot, then it may be quite useful to seek the support of the specialist psychologist or the community specialist nurse, maybe to do a visit and find out what it is that is contributing to the frequency of this patient's sickle cell crisis. And then, consider referral to the clinical psychologist. Before discharge, you need to provide the patient or their carer with information on how to continue to manage the current episode and the preventive measures that they can take, which include obtaining community and other specialist support, where to get additional medications. Most of our patients, they have to get their prescriptions from their GP. If they're on hydroxyurea, it may be that they're getting this from the hospital. So they need to identify where it is that they need to get their continuing medication. How to manage any potential side effects of their treatment that they've received in hospital, and how to prevent future illness and possible complications. So first of all, identifying when they're getting better is usually the ideal time to deal with this. As they're getting better, you're trying to help them to find out what do they think precipitated this current episode. And quite a lot of the patients can identify what caused it. Or, I exposed myself to an infection, I've got a chest infection because, and things like that. Or, I didn't wear warm clothing when I went out and I got a chill. So different things that precipitate the crisis. So you'll be able to educate them, do some health promotion as to how they can prevent future episodes. Not every single crisis can be prevented. And we must always make sure the patients understand that it's not always their fault that they have a crisis, because majority of crises there's no necessarily no cause. Now I just want to share with you any questions so far. No? All right. Should we move on? So this was a cutting from a Metro newspaper. It's quite an old one now, but recent things have happened that are similar to this. And this was a patient with sickle cell disease, which the ambulance refused to take to hospital because she had soiled herself, and it became a major problem because she then died, and these sort of incidents sadly still happen today. I'm sure you all remember the case of a young man, Evan Nathan Smith, who died in 2019. And he was the reason why his death was so tragic was he was in A&E, and he had to call 999, desperate to get treatment, because he felt the staff didn't understand the seriousness of his illness, and they didn't understand the issue that he was experiencing. And so when he died, there was a coroner's report, and the coroner determined that he was neglected. So he was diagnosed with sepsis, which triggered a sickle cell crisis. I mentioned earlier on that the all-party parliamentary group did a report called No One is Listening, and it's an inquiry into the avoidable deaths and failures of care for sickle cell patients in secondary care. I'm sure some of you would have seen that report already. And this person said it should be as shocking for a senior trained medical staff to say they've never heard of sickle cell disorder as it would be for them to say they'd never heard of cystic fibrosis or diabetes. So knowledge and ability to care for these patients is crucial. We are concerned why patients with sickle cell condition should be nursed on wards when nurses are not fully trained to understand the complexities of this condition and respond appropriately. This to us is evidence of substandard care. If one is working in an area where sickle patients are admitted, then it's quite crucial that the staff have knowledge, skill, and competence to look after them. The problem with sickle cell disease is it's a very unpredictable disease. It's a potentially fatal disease. And as a result of that, whatever it is that we do, we need to ensure that we understand the potential fatality of sickle cell disease. Because nurses are often very shocked when a patient with sickle cell disease dies, particularly when they feel that the patient was okay. They thought the patient was okay. They've given pain relief and they thought that the patient was just sleeping, or they thought the patient was just being difficult, and now it's not being difficult. So it's very important that we all need to have knowledge, even those who are not working in especially of sickle cell disease, and how to manage this patient group. This sickle cell patient said, going into hospital as a sickle cell patient requires you to put on an armor, because from the moment you reach A&E, it becomes your job to convince everyone you're really in that much pain and are not simply there for medication. This is very sad because, a lot of patients, as we know, sickle cell is a lifelong illness. And therefore, your experience of medical treatment or the medical environment will also contribute to your distress and your experience of pain. So you'll get, young people, particularly young people, coming into hospital, and they feel they're not being believed, that they're in crisis. A lot of these patients have become accustomed to not necessarily having to keep shouting or screaming in order to express that they're in pain. Whereas, sometimes nurses feel that because the patient is not, grising in pain or rolling in pain, they can't be in pain. And that's why we always say, I particularly like a quote from Aristotle that says, a patient in pain ceases to love. So in other words, when somebody's in pain, he or she is not thinking about the patient in the next bed that needs to sleep. Pain can be very excruciating in sickle crisis. One of the leading consultants in America said sickle cell crisis pain should be treated the same way as a cardiac arrest pain. So in other words, it should be treated promptly, it should be treated urgently, and it should be treated effectively. So it's very important to overlook the fact that this person is a young person, a young man or a young woman, but we've got to put away our own perception of what pain is or should be. Pain is what the patient says it is, and we need to respond actively in managing their pain. Thank you. Any questions?
Hello?
Hello.
Oh, can you hear me?
Yeah, I can hear you.
First of all, thank you very much for your presentation. It's very good. Thank you. I have 2 questions. Yes, my name is Katrina. I work at Chelsea and Westminster Hospital. We're from the pain team. And first of all, my first question is about the treatment. So the first choice, you were talking about PCA for severe long pain, isn't it? Do you recommend subcutaneous, or is intravenous as well acceptable?
We subcut.
Subcut. All right.
Yeah.
But so IV is not advised.
No, some areas do use IV.
Okay.
But we use subcutaneous PCA. So some areas do use IV.
Okay.
So that's why I said it's important to follow your local protocol. Yeah.
Thank you. My other question is in terms. Oh, sorry. Someone wants. I have a question about something.
No, because about PCAs, we have a problem if it's IV. Yeah, it's just that if it's IV PCA, there's a problem with getting access in the middle of the night if it should go everything. So that's why we do in Hammersmith subcut.
Yeah, we use subcut in London Northwest as well. You have to remember, a lot of these patients have very poor venous access.
Yes.
So, you really don't want to be using their veins all the time for pain relief, ideally.
Okay, thank you. My other question is in terms of chronic pain.
Yeah.
So in between if they're not having a crisis, isn't it? What's the common pain they have? What do they? Because you were saying about referring to a pain clinic. What is the common chronic pain that they will?
Most of them is pain. Usually is bone. So you'll find most of them is things like hip pain. Femoral pain. It's usually from bone necrosis is one of the major causes of
okay.
pain. Right. Or if they've got leg ulcers, because you can find even in the teenage years they can have leg ulcers because they have very poor ulcers. And so you can imagine if you're 18, 19 and you've got fulminating leg ulcers, it can be very, very painful and it can be very difficult to treat. Before that we can get it to heal, it can take many years. So, leg ulcer pain, hip necrosis pain are 2 of the most common chronic pain that they have.
Oh, thank you very much.
All right. Any other questions? Was that fairly clear?
Yes, thank you.
Talk to me, guys.
Thank you. It's very good.
Okay. All right. So we're going to be, Ralph is going to bring us back to the main hall because we're going to hear from a patient, who's going to talk about her life experience of living with sickle cell disease.